what are the main side effects of GLPs?
The nausea, the vomiting, constipation, diarrhea, the cramps. It's mainly seen with the semaglutide. When we move to the GLP-GIP, which is the Mounjaro or Retatrutide, we see much less nausea.
Okay.
On top of that, we also see, it's called NAION, non-arteritic ischemic optic neuropathy. It's kind of like an eye stroke.
I'm Veronika Larisova, and today I'm joined by Dr. Sam Zand, double board certified physician and medical director of Evolve Longevity Clinic. Dr. Zand is also a certified obesity physician, which is why we invited him to chat about GLPs, the new age weight loss medications, and their role in today's society. You are listening to the Achieve Life podcast. Sam Zand, welcome to the Achieve Life podcast.
Thank you for having me, Veronica. I'm so excited to be here.
Oh my God, I'm so excited. Ever since I met you at the biohacking event in Miami, I've been dying to talk to you about GLPs. I know it's your topic of passion, and I just keep reading and hearing lots of different crazy stuff about GLPs on Instagram. And to be honest, if I wasn't a health professional myself, I would believe a lot of it, and a lot of it is an absolute crazy rubbish. And I know that lots of people in America and in Australia are on GLPs, so I wanted to have you here today to set the record straight and ask all the questions and bust all the myths.
I love it. I love it.
You
That's
ready
what
for
I'm
it?
here for. Yes.
Okay, so let's start from the basics. What are GLPs actually, and how long have they been around?
So GLPs, it stands for glucagon-like peptides. They were invented in the 1980s.
Wow.
So they've been around for a while. What they have been used for was for diabetes initially. Yeah. And in 2005 is when the first GLP was approved by the FDA, and it was mainly used for diabetes. Fast forward a little bit, then in 2017, semaglutide was approved. Then in 2022, we had tirzepatide. So all of these medications, what they do is that they try to increase insulin sensitivity, make your pancreas produce more insulin to bring down the blood sugar levels. It decreases your gastric emptying, or slows it down. And it also plays there's a huge gut-brain axis connection that goes on to help with the hunger hormones and putting those down, and the combination of all these mechanisms is what we have today.
So it affects the brain via the gut-brain axis.
Oh, big time.
Okay, let's talk about it in detail later. Can you tell us what are all the different types that people use these days, and what's the difference between them?
Absolutely. Very good question. So we have simple GLP-1. We can be the exenatide or the semaglutide everyone knows about, which is also Ozempic.
Yep.
We have the GLP plus the GIP, which is the tirzepatide. It's a dual agonist. And then nowadays we have the Retatrutide, which it's not fully out yet, but that's a triple agonist. So we have the GLP, GIP, and then the glucagon part as well, all in one bundle. Okay,
so what are these GIP and glucagon parts? What they do? What is the difference in the mechanism between Ozempic and and what is the second one? Mounjaro, let's say, and then the Reta. What is the difference?
Perfect. So the GLP-1, what they do is, like we talked about, it slows down gastric emptying. It also helps the pancreas secrete more insulin, and then what the GIP part does, that it like accelerates or makes the insulin secretion a lot better. It also decreases the amount of glucagon secretion we have. Okay, and then the third component, which is the Retatrutide, that one has a glucagon aspect. So that one increases energy expenditure. And it also, what it does is that it reduces, it helps with hepatic fatty oxidation, which means it helps break down the fat around your liver. Okay. So it's been really cool when it comes to that. So Retatrutide officially would probably come out by the end of this year, if not early 2027. So we're very excited about that one.
Yeah, I think lots of bodybuilders are already using it.
Yeah.
That's very interesting, but I have another question. I've heard some people that tried different GLPs. They tried Mounjaro, they tried Ozempic, and they said it didn't really make them less hungry and didn't really curb their cravings. How is that possible?
So that's a very good question. It happens a lot. I see it a lot in practice. A lot of it has to do with if you have the GLP receptor in your brain. So the GLP receptor, first of all, is secreted in your small intestine from the L cells. And then you have receptors all over your body. Every single organ has a GLP receptor on it. The highest density of a GLP receptor density is in your brain. Yeah. There's certain parts in your brain that have that. So going back to your question, why does someone not respond to a GLP as well, is because the GLP-1 receptor expression in the brain is not working as well. Yeah. So another reason why is, let's say we keep increasing the dosage and it's not, the effect is not happening there. So just because we increase the dose, we're not seeing the result. Yeah. There's a lot of data that shows we don't even have that certain receptor. And nowadays we can check it to see if you have the receptor capability in your brain or not.
Wow. So how do you check that?
There's blood work and there's fancy stuff that we can do.
Wow. I want to check it. Not that I need Ozempic, but it's so interesting. Yeah. And so how, do you have any idea how big percentage of population doesn't have this receptor?
I don't know. I would have to. I don't want to make up a certain number, but I would have to look into it because it's pretty fresh data that we're looking at right now.
Yeah, that's super interesting.
Yeah, super interesting. Technically, as far as weight loss goes, with semaglutide, we see around 14% body weight loss. With the tirzepatide, we see around 20%. And then the Reta, which is insane because we are seeing actually like 30%, which is close to levels of bariatric surgery. Yeah. When someone gets bariatric surgery, they get about 33%, 32% weight loss. Yeah. And now we have an injectable that's able to perform as close to what bariatric surgery does.
And so you said the Reta increases your metabolism. How does it do it? Does it increase your heart rate and things like that? Or what's the mechanism?
So what it does is it increases energy expenditure. So it increases your metabolism. Okay. So you start burning a lot faster. It also, what it does is that you start, it's called fatty acid oxidation around your liver. So these are tended for patients that have like fatty liver. There's fat around their liver. So what it does, it helps melt some of that fat off. Okay. 75% of America is obese and overweight. So all these GLP-1s, their main focus was for people that have metabolic disease, diabetes, cardiovascular conditions, vascular conditions. So hepatic fatty liver. So having these medications has really been life-changing for a lot of these patients that I've worked with. Now that it's come to the mainstream media, where we're focusing on the weight loss aspect, we're seeing that there's certain ways we can optimize them without compromising their actual muscle mass and lean muscle mass that they have. So.
Okay, that's interesting. But before we get into the muscle mass, because that's super interesting, I want to know about the side effects, because there's a lot of talks about different side effects. And there's also a lot of stuff on Instagram about lawsuits for vision loss. Is this actually real, or is it just made up? So if you can just tell us what are the main side effects and what are what people can expect to feel.
Very good question. One of the most common side effects are the nausea, the vomiting, constipation, diarrhea, the cramps. You get some headaches. It's mainly seen with the semaglutide, the GLP, just single GLP agonist. When we move to the GLP GIP, which is the Mounjaro or tirzepatide, we see much less nausea. It blunts some of the areas in the brain that are responsible for the nausea. So the GIP component brings that part down. So that's, and then on top of that, we also see what you mentioned. It's called NAION, I have to think about it every single time, non-arteritic ischemic optic neuropathy.
Okay.
So it's kind of like an eye stroke, essentially.
Wow.
Okay. The percentage of that, it's documented, it's about 0.03% to 0.5% have been documented. So it does occur.
But it's very rare.
It's very, very rare. So 0.5% has been like the highest documented case of this.
Yeah.
So what happens is that if you have vascular issues, if you have diabetes, like diabetic nephropathy or diabetic retinopathy, it's much more likely that this would happen if you start a GLP-1.
Yeah.
That's why any person that wants to start a GLP-1 or a double agonist or triple agonist, highly recommend them do blood work, have a physician monitor it so that we can, go about it the right way.
Yeah. Yeah, of course. Yeah, I guess a lot of people just buy it on internet and they don't check anything and just do it. Yeah, that's a big risk. Okay, so you said that they all slow down gastric emptying. Isn't it bad for your gut if the food sits there longer? Does it have any effect on the gut microbiome or actually the muscles in your gut? Like, is it... Yeah,
very good
sounds
question.
really not good.
Yeah. So I don't think it affects. We need more research on the gut microbiome aspect.
Yeah,
but it slows it down, and since you're slowing down, you're less hungry, obviously, because you have a sense of satiety. So the question is it bad for you? Right? Is that what we're trying to?
Yeah.
Yes and no. It is bad. It's bad in the sense that it's slowing down nutrition uptake, but that's why I encourage anyone that's on a GLP-1 diet, we need to do resistance training 3 times a week. You need to increase your protein uptake.
Yeah.
The recommended dietary intake of protein is about like 0.8 kilograms per grams per kilogram.
Yeah.
When someone is on a GLP-1 or any of these agonists, you have to bump it up. It has to be between 1.6 to 2 grams per kilogram. So the only contraindication, if someone comes to me and then they're telling me I have gastroparesis or like I naturally have slow emptying of my GI content, then I'm like, okay, that's an absolute contraindication.
Yeah, okay.
You cannot be on it. That's not for you.
Yeah.
Okay. But as far as being bad, I don't think it's super bad. Okay. But you have to weigh your risks and benefits. That's why it's very important to do a complete medical history. Yeah. Touch base with a physician that knows what they're doing so that we don't have any complications. From literature, we also see pancreatitis, inflammation of the pancreas. You have to look for a family history or personal history of thyroid, a certain type of thyroid cancer called medullary thyroid cancer. It's also important to screen for something called MEN2. It's another, it's called multiple endocrine neoplasia type 2. We have to screen for those to make sure we're not causing any damage.
Okay, so people with those conditions can't have those drugs.
Absolute contraindication. Yeah.
Okay, it makes sense. So I see lots of skinny fat people walking around because of Ozempic, and it's clear that people on Ozempic or any of the GLPs lose weight, and a lot of the weight is muscle. Is this muscle loss only because of the severe caloric restriction, or is the actual drug causing muscle and bone catabolism?
So you're not losing muscle mass because of the medication. It's due to the calorie deficit that's going on because of the medication. So it's indirect. Yeah. So that's why it's very, very important while we're on a GLP-1 or any of these agonists, increase your protein uptake. You have to do resistance training 3 times a week. You get your blood work done. Another important part is the bone density part that you mentioned. Okay, so yes, in premenopausal, postmenopausal women, it's very important to check for bone density. Yeah. I highly recommend it. I know guidelines say about like once a year to do a bone density check. I recommend up to twice, like maybe every 6 months, especially if they're on a weight loss program. because I want to check their muscle percentage, their fat percentage. I want to check their bone density. There can be up to 2.6% bone resorption. So the bone.
But it's purely because of the severe caloric restrictions
Exactly.
and lack of protein and lack of exercise.
Exactly.
Yeah, I just wanted to point this out. I think that a lot of people that I spoke to and a lot of my clients, when they are on this type of drugs, they don't eat properly. They definitely don't have enough protein. They are feeling full, so they reach out for little snacks that are some ultra-processed rubbish, piece of chocolate, instead of having protein. And that's why they're losing the muscle, because they don't want to exercise, they don't want to eat enough protein, and then that's what happens. But you mentioned that the recommendation is up to 2 grams of protein. I've read some study, and I sent it to you as well, that recommends up to 3 grams of protein per kilogram of body weight per day when in severe caloric restriction. Yeah. That is a lot of protein. It would be okay for me. That would be like 150 grams a day, which is doable. But what about if someone is 100 kilos? How can they cover 300 grams of protein in a day?
Hard. It's very hard. I think the study that you mentioned was for high elite intense athletes. Okay. They were mentioning they need to hit the 3 grams per kilograms per protein. Other ways to supplement it, obviously you have a company, nutrition company, so great protein, like for example, there's whey protein, there's casein protein. Casein, you can take it at night. It's a slow releasing nightly protein that you can take. That also helps with making sure you're getting adequate protein in your system at night.
So the protein would be the most important. And then obviously the exercise 3 times a week.
It's key. Because just in general, forget the GLP-1s or anything like that. Resistance training helps you produce bone. Because bone keeps resorbing, and then with like working out, we're trying to help that bone form again. It's a balance between osteoblast and osteoclast. Blast is building, clast is like breaking down of the bone. Yeah. So if we're exercising, it promotes more bone growth.
Yeah. Okay, what about the Ozempic face?
Yeah, that's huge.
Yeah, so is it just because of the weight loss, or is there actually any damage to the collagen in your face because of the Ozempic or Mounjaro or whatever?
I think it's another case of where there's indirect effects of the medication. So lack of nutrients. So, the protein and the collagen and the elastin in your face, if you're not getting enough of your supplements, then it's going to affect how your body is repairing, right? Yeah. I see kids in their 20s on Ozempic, and they don't meet the weight criteria to even be on it. Yeah. And I see that, they're losing elastin. They look a little aged, and I'm like, hey, like, you need to like stop taking this. This is not okay. And I highly don't recommend. There's certain indications and there's certain contraindications, and I think someone that is a sound physician that wants the best for their patient or their friend or loved one needs to give good advice. Yeah. Because that Ozempic face, it's not from the drug, it's the fact that they're just not hungry.
Yeah,
they're not
so it's just too much weight loss.
They're literally not doing it. They're exercising like crazy, and they're just not hungry. Yeah. And that's a recipe for you just aging.
And I think like for a young person who is not morbidly obese, there is no need for Ozempic. What about if they just ate healthily and exercised and drank enough water? It'd probably be the same. Exactly. I understand it's important for someone who weighs 200 kilos and being obese is much worse than any of the side effects of the GLPs. 100%. But for someone who is young and just a little bit overweight, I don't think there is need for it.
Not at all.
But it's what everyone is doing.
Yeah, I mean, they're getting it from the streets, like these. I feel like nowadays everyone and their mother has opened up a peptide company, and with zero medical knowledge or background, and just
and you don't even know what's in it.
Yeah.
That's the most scariest
thing. It's very scary.
Yeah.
And I think there hasn't been enough. I think there's enough good material pumping out about peptides, but also there's not enough, hey, like what happened to me when I had a bad reaction. We haven't seen enough of those videos. Yeah. I think they're just purposely not talking.
Yeah, 100%. Because everyone's trying to sell it. So everyone is saying, oh, it's amazing.
Yeah.
I feel amazing. I look amazing. No side effects at all. By the way, click on the link and buy my Ozempic. Yeah, funny. But I'm really interested to ask you, why have been these drugs used for drug and alcohol addictions lately? How does that work?
Because in our brain, the GLP-1 receptors, they have the highest density in our brains. There's certain parts of the brain, like the ventral tegmentus, nuclear accumbens. Like, I'm not going to say their names. I can't even pronounce half of them. Yeah. There's like 5 areas in the brain where there's high density of these GLP-1 receptors, which there's reward. Right? Mm-hmm. They affect the reward system, the dopamine release system. So, for example, if you were to pick up a donut and take a bite into it, like it would give you like such a huge reward. Mm-hmm. So there's areas of the brain that are recalibrated after you take a GLP-1.
Okay.
So, for example, if before you would get a huge dopamine release after taking a huge chunk out of a bite out of a donut, that's going to be recalibrated. So next time you take a bite out of it, you're like, it doesn't, whatever.
Okay.
I don't really desire that more. What? So how does that apply to us? Like, for example, off-label, we've been using it for alcohol addiction, nicotine, opioids, even like people that are like, let's say, sex addiction too. So I'm not using it just because someone has a sex addiction, but that's a part of it.
Okay.
It reduces the libido.
Well, they can be good and bad though. So, okay, it's great when you have alcohol addiction or sex addiction or whatever addiction, but if it affects your reward center that much, can it kill your ambition, motivation, your normal sex drive, your pleasure from anything in life pretty much? Yeah,
there is. I'm not going to lie. There hasn't been enough studies, but there is enough data to tell us that it does blunt emotion.
Oh, wow. So are we all going to become zombies now? Skinny zombies.
Yeah, so that's, there's only been like about 5 years tops of long-term data on the GLPs. So knowing that, to be determined, we're going to see a lot more of what's coming.
Okay.
Like I said, there's benefits and risks to anything. I always say, you can drink gallons of water, it can kill you.
Yeah.
If you don't drink enough water, that can also kill you too. So it's like, it's finding that perfect balance in life.
I know, but with the GLPs, that's what scares me, what you just said about how it affects your brain. Yeah. And so we don't have enough longitudinal data, you just said, but do you know from what we have, if these effects are long-lasting if you stop taking the drug, or it just reverts back to normal when you stop?
So that's a great question. All the GLP-1s, the primary agonist, secondary agonist, triple agonist, as soon as you stop them, because what it's doing, it's pushing down the hunger hormones, right? We're suppressing them. The moment we remove it, the appetite comes back with a vengeance.
Okay.
So
and your brain function with the rewards and everything comes back.
So you're gonna eat your way back to your previous weight.
Oh my God.
So there's about 67% weight gain after 1 year. So within a year and a half, you'll regain all your weight, pretty much.
So you're pretty much saying that if you want to stay slim on those things, you need to be on it for the rest of your life?
Because this is the reasoning that that they've had. This has been meant for people that are obese.
Yeah.
Right? Obese and overweight.
Yeah.
Not someone that needs an optimization. That does not meet the BMI criteria or does not have metabolic issues such as diabetes or high blood pressure and all that stuff. Someone that has obesity, the adipose tissue in their body has become inflamed, right? It's an inflammatory process. So that inflammation goes around your pancreas, right? So you're becoming insulin resistant. That it's causing diabetes. It's going around your kidneys, not allowing your kidneys to filter well. You get chronic kidney disease. You get elevated blood pressures. It's going and binding to your cardiovascular system, causing heart attacks, strokes, causing neuroinflammation. So the goal of this medication was to, if we can reduce the inflammatory aspect of this adipose tissue, we can, because this is the main factor that's causing a lot of the problems we have nowadays. High, heart attacks, strokes, cancers. There's so many cancers that can be, about 13 cancers can be reduced. Number one causing cancer, if someone is obese, they are gonna have esophageal cancer 7 times more than anybody else. Endometrial cancer more than anybody else. Second highest risk of cancer is esophageal cancer because of being obese. So the goal is for these medications to reduce that toxicity of the adipose tissue so that we decrease all these comorbidities.
Okay.
So in that situation, obesity has to be looked at as it's a chronic disease. It's like hypertension. It's like diabetes. I can't cure it. I can't treat it completely, but I can help you with this medication. But most importantly, your lifestyle modifications. Right? So are you exercising? What are you eating? Are you sleeping? Sleep deprivation is a huge cause of obesity. Sleep deprivation, what it does, it throws off the balance of the whole adipose tissue too. Most people don't know. I wasn't taught in med school or residency that adipose tissue is like an endocrine organ. It releases 600 bioactive hormones. So it has a huge part in causing inflammation or reducing inflammation. So hormones that are estrogen that's released, a lot of fat tissue. There's a hormone that causes it to change testosterone to estrogen. So as you see people gain weight, why do you think a man gets man boobs? It's the higher estrogen content, right? So just to circle back to what I'm saying, yes, if obesity is a chronic disease that we have finally now accepted, a GLP-1, the benefits hardcore outweigh the risks. Hardcore. Okay? That's the evidence behind it. But does that mean we have to ignore? Is it just let me just inject myself and not do all the other stuff? Take good protein intake, good sleep, good mental health, exercise. Those are the key elements. That's just an add-on.
So do you think if people go on the GLPs and change their lifestyle habits, start eating more protein, eat more healthily, exercise, work on their mindset, do you think that would help them to not regain the weight once they get off it? Or do you still think that anyone who is obese needs to be on it for the rest of their life?
I think there's a healthy way of tapering it down. There are tapering down protocols. And I think nowadays what's nice is that there's ways that I've implemented peptides into my protocol so that, yes, we can decrease so we increase the GLP-1 doses and then we can decrease it. So before we're decreasing it, we can start you on certain peptides, obviously gone through blood work and all the proper screening so that we can optimize the patient when it comes to preserving lean muscle mass, making sure they're still they're having visceral adipose tissue, not gaining visceral adipose tissue. So all that stuff will help. Improving insulin sensitivity, helps with sleep. So doing that, mixing that, and then still working on those lifestyle modifications, I think that's key. I think it's better than being like, you need to be on a GLP-1 medication for the rest of your life. I'm the type that I don't like to be on meds for long. There's certain indications, yes, you need it, and then certain indications, hey, listen, let's try to taper you down. I don't want you to be on
Yeah.
a medication for the rest of your life.
Yeah, that's
So
great. I love
That's
that.
just me.
Talking about the inflammation, there's a lot of talks about microdosing GLPs for anti-inflammation. And where I mainly see it recommended is to women in perimenopause and menopause because they're likely to be inflamed. But is the reduction in inflammation on the GLPs only due to reducing the adipose tissue, or is there any other mechanism? Because if I'm not obese and overweight, and I would say, let's say I start microdosing GLPs to reduce inflammation if I'm inflamed, will that make any difference, or is it like, what is the story?
It's tricky. It's tricky because I was reading into that, and there is not enough information. It's very to even give sound advice. Someone that's postmenopausal, I would, where my head goes is the bone density.
Yeah.
I don't want to give you something that will increase bone resorption, right? Obviously, if you're obese, then that's a different story, and you have diabetes and
Yeah.
Okay, well, we're gonna carefully monitor it, but there has not been enough studies to see if someone that is perimenopausal or menopausal that can benefit in the sense of reducing that anti-inflammation, that inflammatory state that is caused by, because menopause, you have low estrogen. That low estrogen is what's causing the inflammatory state.
Yeah.
So not enough data. I think we'll have enough data in the next few years.
Yeah, that's interesting. Yeah, you said 5 years. We have only 5 years of data. That's definitely
Isn't
not
that
long
crazy?
enough to see what happens if you take it for the rest of your life.
Yeah.
So you think that if someone goes onto GLPs, loses weight, and in the process they do everything right, they eat enough protein, they exercise, and they work on changing their mindset, they should be fine, weaning off it slowly, and then be good afterwards?
Yeah, I think that's a healthy way with obviously like medical professional guiding them. I think it's definitely doable. We can optimize someone's performance, decrease their comorbidities if they have any. I think it's a very positive thing, and that a tool that we can use nowadays.
Yeah.
I have friends of mine that have started GLPs, and they used to be heavy drinkers. They barely drink now.
Really?
They
That's
barely
so
drink.
interesting.
They barely drink.
So can you get drunk on Ozempic or not?
You can't get drunk on
You can
Ozempic.
get drunk.
No.
No, you can't.
No. What do you mean by drunk? on
Like
Ozempic?
you said, it blunts all the responses in your brain. So
Yeah.
let's say if I'm on Ozempic or Mounjaro or Reta or whatever, and I go and drink alcohol, will I feel the effects of the alcohol or not?
I think it's just it's not like you will get drunk faster. It's just like it's like your body doesn't want.
Okay, don't
like it
feel
as-
like it.
Yeah.
Okay.
It's like having like kind of like a allergic reaction. Like I don't want this. I don't feel good
like it.
anymore. Like I don't that reward system or that pleasure you used to get from drinking, that euphoria that it causes. It blunts that.
Okay.
So you don't have that dopamine release anymore.
Yeah.
So let's say if you needed like 5 drinks to feel that way, you don't want it anymore because you're not even getting it.
Yeah.
So it's
That's interesting.
yeah.
Do you have any of your patients having problem with sex life because of being on GLPs? If it blunts your pleasure that much?
It's kind of hard to pinpoint it because as far as like it could be erectile dysfunction, it could be psychogenic, right? If they have like intramarital issues, so that can also affect it. Stress, lack of sleep. So are they on GLP-1? Yes, they're all on GLP-1. So it's hard to pinpoint it. But the reduced libido, I've seen it less with like the single and double agonist ones. People that I know that are on Reta, they get it from different sources. They're the ones that complain more about the reduced libido.
Why would that be? Why would that
It's
be?
a stronger medication.
Okay,
it's much stronger.
Okay.
Much, much, much stronger. So I think they're the ones that complain about it. And I know a few. That's the problem. Like, I can't prescribe Reta. It's not available.
It's not available.
Yeah.
And do people on Reta complain about having poor sleep or elevated heart rate? Because you said it increases metabolism, so I'd expect their heart rate to be higher or being a bit anxious or something like that.
No, I haven't seen that yet. I have not seen that.
Okay.
They're looking a lot more fit, I can tell you that.
Yeah.
But they're exercising a lot.
Yeah.
They're eating their protein. They're getting their blood work checked.
Yeah.
They're doing all the longevity modalities to optimize it. That's the thing. The people that are coming on Reta, like that I see, are doing so many protocols. They're the ones that are like, I want to be healthy.
They're the fitness freaks.
They're fitness
Reta
freaks.
is the
they're a different breed.
Yeah.
They're not like
I've noticed that.
It's like, I want to do hyperbaric oxygen chamber after my workouts. I come in for lymphatic drainage. Then I want ultrasound shock therapy for my joints, and EBU. I'll do EBU.
What is EBU?
EBU is like an oil change for your body. It's like mini dialysis essentially.
Okay.
What it does is like it pulls out blood from one arm, it filters it, it ozonates it, oxygenates it, and then it zaps it with UV light, then it comes back. So the goal is to take out heavy metals, microplastics, mycotoxins.
What is the full name of it? I've heard of it.
Extracorporeal blood ozonation and oxygenation.
Because there's so many different things. I also heard about euphoresis or something.
Plasmapheresis.
Yeah, plasmapheresis.
Yeah,
so
that's even more.
That's even more advanced. Oh, wow, that's so interesting.
Yeah,
so,
there's a lot of cool modalities.
There's so many cool things. So is there anything else you would like to tell us about GLPs that we haven't discussed?
Let's see. I think we covered a lot of it. I think your questions were amazing. I
just wanted to make sure that I asked everything, and then we have the good quality information, not some crazy freaky stuff like what I can hear on Instagram. But before we go, tell us more about your clinic. I know that you just opened a clinic called Evolve in South Beach. So if you can just quickly tell us what is it about and what kind of treatments you provide.
That's awesome. I'm so excited about Evolve. So it's a longevity and regenerative clinic that we opened. We focus on deep diving with all the advanced blood markers, deep diagnostic when it comes to imaging. We like to do full body MRI scans on everyone.
Oh wow, you have that?
Yeah, we're associated with Pernuvo.
Amazing.
So we send all our patients to Pernuvo to get a full body scan. We do some really cool blood biomarkers. We even partnered with this company called Age Code. It checks for 1.8 million, it's called single nucleotide polymorphism, so like base pairs in your DNA. Yeah. And what it does, it tells me your true age, and then based on your DNA, based on your epigenetics. And then what it also does, it like customizes, like for example, does Veronica metabolize BPC 157?
Okay.
So based on your DNA and your epigenetics, it's able to customize a peptide panel that you would benefit from.
Wow, that's great.
It's very cool.
I think I need to come and see your new clinic.
We also do the DEXA scan. So with all these weight loss protocols, I like to do a DEXA scan. So we have an in-person DEXA scan. We do the VO2 max testing to see, which is the number one marker for longevity. That's how we assess it. We do the grip strength test. We do, what's it called? We have the PMF bed. So
I love that.
We do ultrasound shockwave therapy. We have a lymphatic drainage.
Amazing.
And we do a lot of regenerative stuff where it comes like exosomes and stem cells and obviously peptides. So really, really nice. We've come up with very good protocols. We've been going to all these conferences nationwide and, bouncing ideas with people in at the cutting edge of this stuff.
Incredible. So I can't wait to check it out.
If you're on the beach, please come out to Evolve.
Yeah, it's at South Beach, and I'll put the links to your clinic in the show notes so people can have a look where it is and come. I have to come myself. Okay, last question that I ask every single of my guests. What is your favorite book?
I like Alchemy.
Alchemist, sorry. Alchemist, yeah.
It's a really good book. I think I read it like 2-3 years ago. It was wonderful.
Yeah,
I loved
it. Classic.
I need to read more books. I'm always reading science. It's not
I'm the same. That's why I ask every guest what's the best book, because it's just for myself to get a good book tips.
I'm like a nerd. Like when I really lock in, I lock in. Like I'm so passionate about something, and I'm like, I wonder how I can help my patient, how I can even help myself. Like, I think some of the cool stuff that's going on right now, as far as like longevity and age reversal. I don't know if you've seen what Dr. David Sinclair has been proposing. It's like mind-blowing.
Like
mind-blowing.
Making blind people see again, and
Unbelievable.
Unbelievable.
And what's crazy is that in the next 5 years, with the help of AI, the sky's the limit.
Yeah.
He was talking about like just rubbing a topical cream on your head and helping the genes that turned off that caused hair growth. Let's turn on that gene so that you can grow your own hair again.
That's amazing.
Insane.
Hope I'm not going to be too old for all these innovations by the time it's approved.
We're living in the perfect era. You know? And the reason why I'm so passionate is because like I'm fortunate enough to still have my parents, and it's like I just don't want them to go.
Yeah.
So it's like everything that I'm learning, it's like how can I help them? How can I help them?
That's amazing.
So like that's where my internal drive comes from.
Love
and
that.
So it's like if I trust myself to do it on my parents, then I'll trust it to do on anybody else.
Well, that's why I'm so passionate about it. It makes sense. Okay, well, that was great. And let's make pact. Instead of just reading science, we both go and read a book until I see you next time. Because it's good to switch off your brain sometimes and just read a book.
Yeah, I agree. I agree. I need to read more books.
Let's read books. Thanks so much for coming.
And
I can't wait to see you next time and talk about another topic.
Thank you so much. Thank you for having me. This has been wonderful.
Thanks so much for listening. If you enjoyed this episode, subscribe to the Achieve Life podcast for more conversations on performance, nutrition, and mindset, and we'll see you in the next episode.